Welcome to Podcasts on Demand, a continuing medical education activity. This activity includes the most recent and current clinical data presented by leading experts. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Great. Thanks so much, Bob. So in the last section, or second to last section, we're going to talk about treatment of frail patients in the newly diagnosed myeloma setting. Please go ahead and submit your questions. And hopefully towards the end, we'll see if we can get to some of those questions as well. And, really, I think Bob touched on this early on in the discussion. It is really important to assess frailty in a myeloma patient. The majority of myeloma patients in the real world are older patients with a lot of comorbidities. And although all of us talk about frailty, we're not very good at assessing frailty. So out here, we've highlighted a bunch of different tools. I think Bob highlighted very nicely the IMWG frailty score. He also gave you the web link to that. That is a really useful tool which uses age. It also uses the Charlson comorbidity index as well as indices of activities of daily living. And it really does provide a good sense of what your patient can tolerate. I think even in this patient population, and specifically in this patient population, it's really important when you come up with what the treatment should be for that particular patient, really focus on patient-related factors. Fitness is a big part of it. Frailty is a big part of it. But in this older patient population, understanding what the comorbid conditions are, cardiac disease, renal disease, unrelated to myeloma, does play into what we pick for treatment. Obviously, one has to consider disease-related factors. Does this patient have very aggressive disease? Do they have extramedullary disease? Do they have disease with high-risk features? And then treatment-related is wherein I think shared decision-making is a big part of what you do in terms of picking treatment for patients, wherein, what is the goals of a patient? How close are they to a treatment center? Do they want to be on oral treatment? How often can they come to the hospital? What kind of a support system, social support system, do they have before we make decisions in terms of what patients can get? So we're going to start off now discussing the MAIA trial. MAIA trial has really been the gold standard of treatment for the transplant ineligible patient population. This was a large randomized trial of nearly more than 700 patients, and they were randomized to the triplet of lenalidomide dexamethasone with daratumumab versus the doublet of len-dex. And this, I really like this trial because it does reflect sort of a real-world patient population. And if you look at this, the creatinine clearance of this patient population was more than 30 out here. So really what you see in the real world out here. And if you look at the data here, obviously the triplets were better than the doublets. So DARA-RD was the winner here with a median follow-up of a little less than 5 years. At 60 months, the PFS was 52.5% versus the overall survival at 60 months of 66.3 months. And when you did a longer follow-up at a median of nearly 90 months, there was a 33% reduction in the risk of death was observed with the triplet of DARA-RD. The median overall survival was 90.3 months. So this is really very remarkable data in this patient population. And this is the bar that has been set. And whatever we see going forward, we're going to go back to the MAIA trial and sort of compare it and see where we are and how much of a benefit the addition of whatever we are adding to this backbone of DARA-RD is going to be. So if you look at frailty here, the Myers trial has done a nice job of looking at frailty. And if you look at frailty, both in the non-frail as well as the frail patient population, this triplet actually did quite well. So adding on the DARA-RD to the frailer patient population, you do see an improvement in progression-free survival, which is quite remarkable. So based on the data from the Maya trials, we have a polling question here. Which one of the following is true for the transplant ineligible newly diagnosed patient? DARA-RD was associated with a 33% reduction of the risk of death. B, DARA-KRD was associated with 33% reduction in the risk of death. C is ESA-KRD was associated with a 33% reduction in the risk of death. D, ESA-KRD plus autologous stem cell transplant was associated with this 33%, or was it ESA-VRD? All right, I think the majority of you have answered as A, which is the correct answer here. We did talk about the Maya trial, and we saw that there was a 33% reduction in the risk of death when you added DARA to the RD backbone. So, in this patient population, we've actually done the modified RVD, and I think this is really important, and this is very close to my heart, because I think in this older, frailer patient population, modifying the treatments and modifying the dosing is really critical in terms of how patients can tolerate this. This was a small study. It was a phase 2 study, but this phase 2 studies really has been adopted by the majority of people the world over. Here we used a lower dose of lenalidomide. Bortezomib was given weekly subcutaneously, and the dexamethasone dosing was also much lower. And if you look at this patient population, again, the transplant ineligible patient population, we saw an overall response rate of way above 85%, and VGPR or better was seen in 80%. This translated into a progression-free survival of about 33%, with overall survival, median overall survival not reached. So as long as you can modify the dosing schedule of drugs, most patients can tolerate whatever is available for patients. And I think this is where frailty becomes a big part, assessing frailty and then dose modifying drugs in the context of myeloma is really important. We're also doing another trial where we're using a quadruplet. Pete is a part of this. This is part of the Alliance study where a quadruplet is being used. This is an all oral and subcutaneous, so it's DARA-IRD. In this case, it's ixazomib with lenalidomide and dexamethasone, and hopefully we will present some of these data later on at some meeting either this year or next year, we shall see. There are other strategies which have been used to modify dosing, and this is a really nice trial from the IFM. This is the IFM 2017-03 trial, which is a dexamethasone sparing regimen. When Pete so nicely showed us all of the different drugs in myeloma, I think the hardest drug for most patients to tolerate is the dexamethasone. So this was a trial where dex was actually not used with daratumumab and lenalidomide. So if you look at DR versus RD, you see that the overall response rate of dara lenalidomide is much higher, and including the MRD negativity. So you can come up with dosing regimens where you're using a steroid sparing regimen, and this is specifically important in patients who are older, who have other comorbidities such as diabetes, heart failure, and so on and so forth. So really effective regimen without the use of steroids in this case. This then leads us to what was presented at both ASCO and EHA as a late-breaking abstract. This is the IMROS trial, and what we are now using even in the older non-transplant eligible patients is 4 drugs, and this was the IMROS trial using isatuximab on the backbone of VRD. So ISA-VRD was used. There was an induction phase wherein 4 6-week cycles were used. This was followed by ISA-RD continuous, so continuous up until progression. And if you look at the progression-free survival of ISA-VRD, the median PFS has not yet been reached at a follow-up of close to 5 years, whereas the VRD arm, the median PFS of that was about 55 months. So really remarkable results. And if you think about what you saw with Maya, this is certainly an improvement. So addition of the bortezomib to the DARA-RD or the CD38-RD backbone does add to the progression-free survival benefit in this patient population. Now, if you look at the IMROS trial again, and if you look at the overall response rates, there was an improvement in the VGPR rate of the quadruplet compared to the triplet. And specifically, even in this patient population, we are looking at MRD negativity rates. And if you look at MRD negativity rates, those were increased in the quadruplet compared to the triplet. And the median time to MRD negativity was also substantially different, wherein within 14 months you saw an MRD negative rate with the quadruplet compared to the triplet. Now, looking at all the different subgroups in the IMROS trial with the ISA-VRD, you saw a benefit in terms of, if you look at the hazard ratio across all of the different groups, you see a benefit of the quadruplet based on age, performance status, cytogenetic risk, stage, and so on and so forth. This then led to the benefit trial. This is an IFM-driven trial, and what they did here was used it's almost like a Maya comparison here. So an anti-CD38 monoclonal antibody with lenalidomide compared to VRD with the addition of isatuximab. And if you look at the data out here, this data, we don't have the PFS yet, but you see that the MRD negative rate has been substantially increased, and we know that MRD negativity translates into a progression-free survival benefit. So patients who achieved MRD negative at a rate of 10 times minus 5 with ISA-VRD was 25% compared to just about 10% at 12 months, and this depth of response kept increasing at the 18-month time point with the addition of bortezomib to the backbone of the anti-CD38 with lenalidomide and dexamethasone. There's an ongoing trial. This is called the Cepheus trial, very similar to the IMROS trial. This is VRD, but instead of using isatuximab, it's going to be daratumumab, and hopefully we will see data on this trial later on this year at a meeting either at the International Myeloma Society or at ASH later on this year. So that brings us to this case. This is a 76-year-old retired nurse. She presented with a pathological fracture of the lumbar vertebral body. Further workup revealed anemia, borderline elevated creatinine with some hypercalcemia. She was noted to have an IgG kappa multiple myeloma. She did have high-risk cytogenetics, which included a P53 mutation. There were no other notable translocations. So this was a transplant-ineligible patient with newly diagnosed myeloma, also had high-risk features. And this is your polling question. What would you consider as initial treatment strategy? Would you consider using DARA-RD in this patient? Would you consider using RVD light? Would you go with the quadruplet of DARA-VRD? or ISA-VRD, as we've seen in the IMROS trial, or would you consider DARA-IRD? I think the bottom line is most people are using a quadruplet, but I'm just going to pause here and pull Bob in first and then Pete as well, just to see what Bob, looking at this case out here, high-risk disease, older patient, has some renal insufficiency, but may have been because of hypercalcemia. What would you consider as your go-to regimen here?
Yeah, definitely. I think really any of these options are reasonable, but at least from what we are told, there's no evidence to suggest significant frailty in this patient, and the high risk feature would argue in favor of incorporating a proteasome inhibitor. So I do think that C, D, or E are reasonable, and I would say that because we now have the IMROS data, that probably ISA-VRD, option D, is the one that we have the most support for of the 5 here.
Yeah, but Pete, would you do anything different?
No, I think Bob's absolutely correct. If you want to go with level 1 evidence, the IMROS regimen, ISA-VRD is the right answer here. The CD38 antibodies, both DARA and ISA, have performed well when added to standard of care regimens. So I think we all know what Cepheus is probably going to tell us, but until that day, I think IMROS is the right answer.
Yeah, and I think just for DARA-IRD, I think we don't have, the I, which is the ixazimib, is not yet approved in the upfront setting. So unless it's on a clinical trial, we cannot really do that. And hopefully, like I said, we'll present some of that data in the future. Moving on to the next patient, this is a 79-year-old gentleman. He has long-standing IgG kappa MGUS for which he was followed by his hematologist for more than 10 years. While playing golf, he noted low back pain. He underwent further workup, and he had an M component of 3.5 grams with a new acute compression fracture of L2. There was no evidence of cord compression. On testing of his bone marrow, he was noted to have the 11-14 translocation and hyperdiploidy. So again, with his age 79, he was transplant ineligible, newly diagnosed with these cytogenetic features. You have a polling question for him. What would you do in terms of treatment? A is DARA-RD, like the Maya trial. B would be RVD light. C would be DARA-VRD. D is DARA-MPV, or E would be DARA-VTD, as done in the Cassiopeia trial. So this was a gentleman with standard risk cytogenetics 11-14 hyperdiploidy. And again, I'm going to ask our faculty, and we'll start off with you, Pete. With this gentleman in 2024, what would you pick as your treatment of choice?
So the 79-year-old was golfing when they fractured their vertebra. So presumably this patient is relatively fit. So you could make the argument for a quadruplet in this case. And although this was not one of the answers, I think the benefit regimen, where you're using ISA-Len-Dex with gentle bortezomib would be a really nice choice for this patient in their late 70s. I think DARA-Len-Dex is a perfectly appropriate answer for a patient with standard risk cytogenetics as well, or if this patient had had significant comorbidities and was not on the golf course when they fell apart.
Yeah, I think that's a perfectly reasonable answer here. I think the benefit trial has shown us a doubling of the MRD negative rate, and that would be a perfectly reasonable option for this patient, because what they've done is use sort of the RVD light backbone and added in the anti-CD38. Bob, any other thoughts around this patient?
I agree very much with what Pete said. I think probably going the other way and saying what's least interesting here. I would probably try to avoid DARA VTD. Pete mentioned earlier the neuropathy that you can see with the combination of thalidomide and bortezomib, and that can be particularly troublesome in more mature patients, shall we call them, and they can also get constipation. And as most people know, melphalan is not exactly a terribly popular drug to use as part of induction therapy. So I think DARA MPV, although officially approved from the Alcyone study, would be probably also not my favorite here. So I think D and E would be definite negatives.
Yeah, I think most of us on this side of the pond would agree with that. So just to summarize what we've talked about is outcomes with continue to improve. Triplets, I think, are certainly standard. And with the data that you've seen at ASCO and EHA, quadruplets are really taking a hold. And there's data now to show modified dosing with the quadruplets also. I think frailty is really important, and we sort of underappreciate it. It's hard for us to analyze how patients are frail versus not. So using some of the tools that we've talked about are really important. And as we start using triplets and quadruplets, because we are seeing such high response rates in all our patients, focusing on MRD negativity, even in the older, less fit patient population, is the key to translating into longer-term outcomes. We obviously have to focus on the toxicities of all the treatments that we do as well. With that, I'm going to switch gears and move to Pete again. Dr. Voorhees is going to bring us home with what's new in the newly diagnosed space. Pete?
Thank you, Nupur. So I'm going to be talking about what's coming down the pike for newly diagnosed myeloma, and this will get at one of the questions in the chat. So there's a number of different immunotherapy approaches that are being studied as we speak for newly diagnosed myeloma patients. The three studies that are depicted here are for patients that are not undergoing an upfront stem cell transplant. And the common theme amongst the three studies is that they have T-cell redirecting agents incorporated into kind of standard treatment. So Majestic 7 is a study that will actually evaluate Daralan-Dex versus teclistamab, the BCMA bispecific antibody, with Daralan, and there's actually going to be a talquetamab Daralan arm in that study as well. So it's a 3-arm trial. Magnetism 6 is looking at the BCMA bispecific elranatamab in combination with daratumumab and lenalidomide against Daralan-Dex again. And then Cartitude 5 is a study that's looking at induction therapy with VRD, followed by consolidation therapy with cilta-cel, CAR T-cell therapy, and then maintenance therapy. So these studies will establish whether adding either the BCMA bispecific into the backbone or consolidating with BCMA-directed CAR T-cell therapy with cilta-cel is effective and safe in this patient population. With that in mind, part of the safety run-in of the Majestic 7 study was presented at ASCO this year. So this is the patients that received teclistamab. Again, that's a BCMA bispecific antibody with daratumumab and lenalidomide. Relatively short median follow-up, just over a year, but the overall response rates are over 90%, and virtually everybody has achieved at least a very good partial response, and the majority of patients have achieved a complete response as well. And as we all know, that those responses will probably deepen with longer follow-up, so they're off to a very good start. So Cartitude 2 is a platform study that's looking at the use of the BCMA-directed CAR T-cell product, cilta-cel, in a variety of different clinical scenarios. So Cohort D was a group of patients that had been through initial induction therapy followed by transplant and had not achieved at least a complete response after the dust settled from their transplant. So these patients underwent apheresis followed by lenalidomide bridging therapy. They then received lymphodepleting chemotherapy with fludarabine and cyclophosphamide, followed by cilta-cel. After their counts recovered from cilta-cel therapy, they then went on to lenalidomide maintenance therapy. And as you can see here, the overall response rate was 94%, with the overwhelming majority of patients achieving at least a complete response. And as you can see here on the right-hand side of the slide, with relatively short follow-up, MRD negative rates are quite high, and we expect those to improve with longer follow-up. I think that this is important. So again, very small numbers of patients, so take this with a grain of salt. But while cytokine release syndrome was common, there was no grade 3 or 4 cytokine release syndrome in these patients. The rates of ICANS was lower than what we saw in CARTITUDE-1, for example, at only 6%. And none of those episodes were grade 3 or 4 in severity. And the rates of heme toxicity were also lower in the study as well. And I think this speaks to the fact when you give CAR T-cell therapy, when the burden of disease is low, the side effect profile of these agents is far more favorable. And with that, I'm then going to pass back to Dr. Raje to talk to us about what else is coming on the horizon.
Sure. Thanks, Pete. So, as you pointed out so nicely, as we move these immunotherapies early, we hope to see better responses. It's just not just the disease burden being lower, they being able to tolerate these treatments better, but also your T cell function and health be better. So there's a bunch of newer CAR T cells also in clinical trials. Equicell is one of them. This is a fully humanized BCMA specific CAR T cell. A trial has been done in a small number of patients, and this is now being tested in the United States as well with the same drug product targeting BCMA. Similarly, we have this, which I think is really an exciting new way of making CAR T cells. It's called the fast CAR T cell. It's GCO12F. It's a dual targeting BCMA CAR targeting BCMA as well as CD19. The beauty of this CAR is the turnaround time of 5 days, because those of us who use CAR T cells, the 4 to 6 weeks of the waiting time frame is not necessarily what most patients can tolerate. So this data was presented at ASH. There were 22 evaluable patients, and the median follow-up was a little short of 2 years. The overall response rate here was 100%, with the progression-free survival at 18 months of 95%. So really remarkable results. We need to confirm this in a larger centered studies going forward. There are lots of areas of unmet need in the newly diagnosed space. We've touched on some of these. Frailty is a big part. So although we've talked about all of these quadruplets, not everybody can tolerate a quadruplet. So we really need to figure out how best to treat this. There are certain situations like primary plasma cell leukemia, which is a really high-risk disease type, and it's extremely hard to treat and remains an unmet medical need, as with things like CNS involvement with myeloma, albeit rare, it does occur, as well as with patients with extramedullary disease. Even with the T-cell redirected treatments, this remains an area where we need to be able to do better in this space. So there are certain pressing issues in the newly diagnosed space, and these hopefully will be answered in the next several years. When should a quadruplet regimen be preferred over a triplet? And I think in the majority of patients now, most of us would agree that a quadruplet is what we would be using. Are these what we are going to see is updates in how we use maintenance, specifically when we start using quadruplets. And I think this speaks to what Dr. Orlowski showed us very nicely early on with the master trial, where for the first time we've actually de-escalated treatment with the use of MRD. Not for all patients, not certainly for the high-risk patients, but there may be a standard risk group of patients where after a quadruplet, you can actually stop treatment. And how will sequencing therapy decisions change over time as we start using all of these combinations up front? So I'm just going to leave you with this treatment algorithm for the newly diagnosed myeloma patient. I think this keeps evolving. Every time we sit down and give a talk with myeloma, this changes around a little bit. But in a newly diagnosed myeloma patient, if a patient can go on to a clinical trial, we should always think about that, then assess the frailty of a patient. We're going to start moving away from the transplant eligible versus ineligible because we are seeing such high response rates. But based on fitness, I think genetics do make a difference, and that does play into our decision making. And although continuous therapy seems to be the norm right now, with some of the data that you've seen already, we may be beginning to question that going forward. So with that, if we have time for questions, Pete and Bob, if anybody's been monitoring the chat room, do we want to go there? I'll hand it back to Dr. Orlowski.
I'll be happy to take it back. Thanks for the great presentation. I think we have time for a couple of questions. One question that we didn't cover a lot about is on consolidation therapy. In your practice, how often do you add consolidation after autologous stem cell transplant for your myeloma patients? Pete, do you want to tackle that one?
Sure. So I think in the U.S., it appears that the post-transplant consolidation is not being used very commonly. If you look at the Perseus trial, there were 4 cycles of induction and 2 cycles of post-transplant consolidation. Same was the case for CASCP and Griffin. If you look at GMMGHT7, there were 6 cycles of induction given before transplant. So the common theme is 6 cycles of therapy. And I think if you're going to reproduce the results of these trials, particularly when you look at the Perseus results, you need to do what they did in the trial. And I like the idea of splitting up the treatment into induction and post-transplant consolidation, because one of the things that we've noticed when you give a CD38 antibody with lenalidomide as part of induction therapy, that does have an impact on stem cell mobilization. So I typically recommend 16 to 18 weeks of induction therapy and then collecting those stem cells. If you go beyond that, you start to run into trouble. So if you break up the treatment into 4 cycles of induction and 2 consolidation cycles post-transplant, that gets you your 6 cycles without compromising your ability to collect stem cells. So I think we need to start moving more towards that, because I suspect we may be undertreating at least some of our patients.
Very good. And I think got a new question that came in, which we didn't really cover, but might be useful to do, which is about solitary plasmacytomas. Dr. Raj, maybe we'll punt this to you. Is there a role for systemic therapy in larger size solitary bone plasmacytomas? And the example given is 8 to 10 centimeter, which is a pretty decent size. Or is definitive radiation enough? And what about the entity of multiple or more than one plasmacytoma? So kind of 2 questions there.
Yeah, so great question, really. And, this is not an area where we have a lot of data. I will say that if you have more than one plasmacytoma, we almost consider that as macrofocal disease. And we do see that happen in patients. And those are the patients that I would use systemic treatment, because although they don't have a lot of disease in the bone marrow, the fact that they have multiple plasmacytomas, you're not just going to be using radiation treatment there. For larger size plasmacytomas, it really depends on where that plasmacytoma is located. For example, if you have a plasmacytoma which is 8 or 10 centimeters affecting the sacrum, we have such effective systemic treatment that I am not going to radiate that sacrum, because you're going to cause problems to the stem cell yield. And that's one place where I would absolutely consider using systemic treatment. Use a combination approach. They will need 3 cycles, and that's going to melt away. And by doing so, you're going to limit the use of radiation, and you're not going to cause stem cell toxicity. So for those reasons, I would consider using systemic treatment in patients with a plasmacytoma.
It's probably also worth mentioning to keep in mind the possibility of doing bilateral bone marrows, especially on people who have plasmacytomas outside of the pelvis, because you just want to make sure that you don't have involvement of the marrow on either side, because that can change things. And my habit is to consider that the patient has multiple myeloma in most cases, even if there is a low level of involvement on flow. We also have a question that just came in about plasma cell leukemia. We talked briefly about the fact that this is a really aggressive disease and a high risk, typically molecular abnormality is present. And the question, Pete, will send this to you. Would you use VT PACE in this era, or would you be comfortable doing one of the quadruplets that we talked about here?
So I think increasingly we're moving away from the multi-agent cytotoxic strategies for this group of patients. I think, this is a ultra high risk version of multiple myeloma. And I do think that quadruplet therapy followed by a single stem cell transplant and maintenance therapy is insufficient. I think in this particular case, you would either want to follow the script of the GMMG concept study, where they do quadruplet therapy, they do a single transplant, but they do this extended course of multi-drug therapy afterwards, which is why I think that they're seeing good outcomes in what was a very high-risk patient population in that study. Or I would consider something like the IFM study, where they did the DARA KRD followed by a tandem transplant. But this is a patient population where we really need to incorporate the bispecific antibodies and CAR T-cell therapies as part of the initial treatment strategy.
To that, I would just add, Bob, this is one place. So plasma cell leukemia can be associated with the 11-14 translocation. So it's really important to look. And if you do find that adding on the BCL2 inhibitor here, like venetoclax, is also important. And again, this is where you use a quad and get them to an immunotherapeutic strategy as early as possible.
Very good. Well, thanks to both of you for a great discussion and for answering at least some of our questions.
Thank you for joining us in this final episode of Integrating Quadruplet Regimens in Newly Diagnosed Multiple Myeloma. Please return to the landing page to access the downloadable slides and other related topics.
We hope you found this podcast useful and educational. To receive continuing education credit and to download your printable certificate, please go to the activity page at practice.cme.com to complete the post-test and evaluation to receive continuing education credit.